The Conformis iUni G2 is a patient-specific unicompartmental knee resurfacing system. It is designed for the treatment of moderate to severe osteoarthritis isolated to the medial or lateral compartment. By utilizing proprietary technology and data from a patient's CT scan, implants are customized for each patient. The surgical technique for the iUni G2 resurfacing system is performed using patient-specific disposable instruments called iJigs. They're employed in the following 6 steps. 1. Site preparation. 2. Balancing the knee. 3. Tibial cuts. 4. Femoral preparation. 5. Tibial preparation. 6. Cementing implants. Every iUni G2 system ships with a set of iView patient-specific surgical planning images. The iView images provide information on osteophyte removal, with the orange osteophytes denoting the specific areas that overlap with jig fit. The images also provide the values of the designed posterior condylar resection and the tibial cut slope. Step 1. Site preparation. Position the patient on an operating table with the leg resting on a foot support at around 90 degrees of flexion. After a short midline skin incision, perform a parapatellar arthrotomy. The MCL can be released away from the tibia using a curved quarter-inch osteotome, taking care not to damage any fibers. Remove all femoral and tibial osteophytes, including those in the intracondylar notch and edges of the femoral condyle, using an osteotome or a rongeur. Remove osteophytes from the edges of the femoral condyle down to the subchondral bone. Proper removal of osteophytes will facilitate accurate iJig alignment and orientation. Next, place the femoral iJig on the condyle and mark the anterior edge of the femoral iJig. In most cases, the anterior edge of the femoral iJig seats approximately 1 to 2 mm inferior to the linea terminalis. Remove all cartilage beginning about 2 mm posterior to this mark, including the posterior condyle, using a 10 mm blade and a curved elevator or ring curette. Insufficient cartilage removal may result in improper positioning of the balancer chip and a potentially thicker tibial resection. Then perform a complete meniscectomy and scrape residual cartilage from the tibial plateau, as well as the tibial spine on the affected side. Remove all tibial osteophytes that may tension the ligaments or interfere with balancer chip placement. Finish the cartilage removal using a 5 mm ringed curette down to the subchondral bone. Step 2. Balancing the knee. Select an appropriate balancer chip from 4 available sizes to achieve the desired ligament tensioning. The chips are designated A, B, C, and D, and increase in thickness by 1 mm incrementally. The balancer chip is designed from the patient's CT scan and needs to be touching subchondral bone on the tibial plateau and distal condyle. Next, insert the selected balancer chip in flexion between the femur and tibia with the flat surface facing up. The superior surface has a flat geometry to allow for referencing off the distal femoral condylar surface. The inferior surface is designed to conform closely to the topography of the tibial plateau and will self-seat in a stable position. Then bring the knee into 0 to 15 degrees of flexion and confirm the desired tensioning. Repeat until the balancer chip that provides optimal ligament tensioning is identified. Most patients will be properly balanced using a B, C, or D chip. If an A chip seems to provide the best balancing, confirm that all tibial osteophytes and soft tissue have been removed and rebalanced before proceeding. If the selected balancer chip is providing the desired ligament tensioning in extension, but expulses anteriorly in flexion, revisit the tibia and femur for any residual posterior meniscus or cartilage. The posterior meniscal horn can keep the balancer chip from seating properly and may affect posterior slope. A laminar spreader can provide access to the posterior aspect of the knee and facilitate removal of the meniscal horn. 1 to 2 mm of play medially and 2 to 3 mm laterally will be observed with the selected balancer chip when applying varus or valgus pressure. A tight joint may lead to the overstuffing of the contralateral compartment. Step 3. Tibial cuts. Slide the dovetail feature of the tibial iJig onto the tibial alignment rod. With the leg in flexion, slide the tibial iJig onto the post on the front of the balancer chip and seat the tibial I-jig flush against the anterior tibial surface. If the tibial I-jig does not rest flat against the surface, revisit the tibia and remove anteromedial osteophytes. The posterior slope can be visually confirmed by viewing the sagittal position of the up rod. Next, check that the tibial alignment rod is parallel with respect to the tibial eminence. This will confirm the position of the tibial I-jig prior to pinning. Drill and pin both holes on the tibial I-jig, and remove the tibial alignment rod if desired. The mesial tibial pin is designed to enter under the contralateral compartment to avoid drilling a second hole under the affected compartment. Attaching a coker to the end of a pin will help further stabilize the tibial I-jig during sawing. With the knee still in flexion, perform a sagittal tibial cut using the tibial I-jig. The saw blade should be flat against the metal cut guide. The reciprocating saw blade can be left in to protect the ACL insertion while performing the axial cut. Then perform a horizontal tibial cut using the tibial I-jig. Remove the tibial I-jig followed by the resected bone segment. With the knee in flexion, insert the tibial template and confirm the profile of the tibial cut. Revisit the sagittal cut if excessive lateral or posterolateral overhang is observed. Step 4. Femoral preparation. Attach the L-guide to the bottom pinhole on the femoral I-jig and place it on the condyle with the knee in approximately 90 degrees of flexion. Adjust the angle of flexion until the L-guide rests flat on the 8 mm spacer block, while the spacer block touches off on the posterior condyle. Next, verify that the femoral I-jig is stable in its AP and ML positions. The femoral I-jig should also be flat against subchondral bone and central on the condyle, as seen through the anterior and peripheral openings. Confirm that cartilage removal at the anterior margin provides a smooth transition now that the femoral I-jig is in its final position. The thickness of the L-guide is equivalent to the posterior femoral resection. The L-guide can be removed to observe the amount of femoral resection prior to drilling. Drill and pin the femoral I-jig beginning with the proximal pin, using the blue disposable femoral pegs marked F. Remove the L-guide and spacer block in order to drill and insert the second pin. Begin the cut with the saw blade angled up slightly, and then straighten the blade for a flat cut. This will prevent the saw blade from skiving off the posterior condyle and producing an angled cut. Make a posterior femoral cut and remove the bone. Once condylar resection has been made, revisit the posterior condyle for any large osteophytes. Next, round the resulting anterior sharp corner from the femoral bone cut with a burr, rasp, or curette. Place the femoral trial on the condyle and mark the transition zone between the trial and femoral cartilage using a marker. Create an inset for the anterior margin of the femoral implant with a burr. Finish by verifying the placement and depth of the insert with a femoral trial. With the femoral trial in place, insert the orange 8 mm spacer block and evaluate the balance in flexion and extension. Joint play of 1 to 2 mm is desired for the medial side in extension and flexion. For lateral cases, 2 to 3 mm in extension and flexion is desired. If the joint is tight in flexion and extension, resect an additional 1 to 2 mm off the tibia while maintaining the same tibial cut slope. If loose, insert the blue 10 mm spacer block and evaluate the balance in flexion and extension. Step 5. Tibial preparation. Place the provided stop sleeve onto the drill bit for tibial preparation. Place the tibial template and drill both holes to the stop sleeve. The tibial template should be flat against the vertical resection and follow the outline of the cortical rim. Next, using the orange disposable tibial peg marked T, pin the posterior hole only to accommodate the fin hole preparation instrument. Create a keel hole using the tibial keel punch preparation tool or a 1/4 inch osteotome. The tibial keel punch should be inserted with the curve facing out and with the handle angled parallel to the tibial peg. Impact the keel punch by striking at the proximal end with a mallet. Step 6. Using a perforator drill bit, drill approximately 8 to 10 cement holes to enhance cement interdigitation on the femoral cortical surface. Then irrigate the joint. Place the metal implants into position, tibial tray first, and insert a 6 or 8 mm trial poly, corresponding to the spacer block used to confirm optimal balancing. Remove the implants, femur first. Next, apply a layer of cement to the tibia, filling holes and covering the bone surface. Insert the tibial tray at an angle and press down such that excess cement extrudes anteriorly. Then impact the tibial tray using the tibial impactor tip. Remove any residual extruded cement from around the implant, with consideration for any cement that may have extruded posteriorly. Apply a layer of cement to the femur, filling holes and covering the bone surface. Impact the femoral implant using the femoral impactor tip. Insert the selected trial poly and bring the knee into 45 degrees of flexion, allowing equal pressurization of the components. Remove any residual extruded cement from around the implant. Remove the trial poly and check for posteriorly extruded cement. Insert the selected poly size, posterior end first, at an angle. Finish by snapping the poly into place, by pushing down on the anterior edge with the heel of the tibial impactor tip. Thank you for reviewing the iUni G2 surgical technique animation video. For further technical information or surgical training material, please contact a Conformis representative.